bed ratio is 3.8 beds per patient. Each have about 6 million admissions to hospitals and about 42,000 deaths. Each person who is in hospital will be treated at hospital, and the hospital will maintain a bed head ticket, normally which is called in some other countries. This head ticket, charge, death or transfer. This diagnosis or probable diagnosis to the medical records room. At the medical record officer will code this into CD10 classification. A system. This will be recorded in a Indo-Morbidity Mortality register, which contains 266 disease categories. At the end of each quarter, this will be summarized into Indo-Morbidity Mortality return, which to the medical unit by the institutions and through the regional centers by the regional institutions. In fact, we have two types of institutions. Some hospitals owned by the central government and some are by the regional administrators. So the central government institutions will send this report directly to the medical statistics unit. The institutions report through regional regions. At the statistics unit, will be and year produce a book called Annual Health Bulletin, which is all data accumulated from all hospitals throughout the country. The morbidity, IMMR or Indo-Morbidity Mortality return 276 diseases or disease categories, and they are reported according to fixed age group. To 16, 17, 59 and above 70. Bulletin. Medical Statistics Unit since 1985. It gives information of the health sector of Sri Lanka. This bulletin means sector and present information on 4 major areas: mobility, mortality, is available, and there were major shortcomings of the paper-based system. Many aggregation of is during the process of data flow to the MSU. Once it's at the hospital level, because they are entered into a book and then aggregated in the report. In the regional center, where they are aggregated into one report, and in the center, where the statistics unit will consolidate. This type fuming and error. Further, the data collection format was outdated. Data formats with different age groups I discussed earlier. For example, most of the injuries will go on to a wine. A fracture of the femur and fracture of the skull will be reported. Therefore, this is limited. Some of the categories are outdated. Large data is appearing under non-specific rules. First, sometimes and accuracy was like working, especially because and sector will receive only aggregated data. It's quite hard to trace the individual cases in case there is an error or probable. And it was very hard to get real-time data, and manpower requirement for the whole process. Another shortcoming in the system, we report public data or owned by the government sector, which treat more than 50% of outpatients and of inpatients was ignored. They was just, it was in a paper-based format. So, from all these shortcomings, which was to cap this hospital morbidity and mortality data. To tell me system, I'll hand it. Good afternoon. As my solution called eIMR, it has a web-based system. This web-based system is the data entering is done only once. Not like the manual system, there are no steps involved. Just the entry is one, and all the user levels in the system, they can visualize the data. This is hosted as www.imr as well to train all the users who are using the system. Right. As I said, since capturing the data, the data analysis capacity is very much high, and we analyze data according to ICD code, and we can calculate patient days for each and every diseases separately, and can generate graphical and geographical. Sourceability of data is very much high with the eIMR system, and so since it is a web-based system, the data sharing is and we can monitor the progress of data entry at the central level, and by introducing this system, we are able to cut down many costs, save a lot of money for the country, and also able to publish annual bulletin timely. So this we have started way back in 2010, and at the beginning done a pilot 1 year in major hospitals in the country, and at the beginning we were able to Vishwabhimani award for the system, At the end of the pilot, at 2001, we had a satisfaction survey as well as a comparison study between assess the the accuracy. We had a lot of discussions at the ministry level with Secretary of Health, and at 2012 June, given us the permission to implement the system island-wide, and a circular was issued for the guard, and from that we implemented the system throughout the country. But at the beginning, it was problematic because most of hospitals in the country didn't have the expected facilities. So we have to provide them with the computers, the internet connections, and so in 2013 has identified PIMMR as one of their disbursement link indicators for health sector development project. One of the major milestones we have achieved because this is able to provide facilities for all institutions use by time we have developed the newer versions to overcome the problems, and at the beginning of this year, January 2000, launched the latest, which is 4 of the this is actually it needs, as a small web-based system, to run the system we need a computer and internet connection to each record room. And the facility survey we have done at 2010, we have found out that only 22% of record rooms in the country has computers, and only % of them have this internet connectivity. Here we have to provide to the health sector development project and provide these facilities to them. And we have conducted training in each and every RDHS area every year to train the people who are handling the system. So it coming at the beginning, but we were able to train about 1,300 people all over the country to run the system smoothly. And every year we have conducted several programs, hospital inspections to the risk and the process. To use the system, they need to have a training. This is essential to have a training on ICD classification system, the International Classification of Disease. With NIH's Kalutara, we conducted at least 3 or 4 programs classification system. Tagged by India Development Project. So to this you can see in 2013 the 15% of institutions has to send their data through this to achieve the health sector development project. But our target is not this. Once we finish this and achieve 100% coverage island-wide. So these are disbursement link indicators given by So you can see the third and fourth one is to the IMR implementation. Actually, third indicator says it is the number of institute data through their data through the system. And the fourth one is for the provincial institute. Right. This is at the 30 hospitals in the country. Using 40% of all the institutions are sending their data through this system, and it considers 20% of admissions in the country. I mean, of the admissions we are collecting through the system. So, system at the moment. Now, my colleague will discuss the advanced and the EIMR we have developed recently. Much with the initial system was capturing diagnosis, date of admission, the discharge, the BH age, and details pertaining to the location, such as ward or preference. But since the system, the users and the users center or at center required many to be added. So developers, we had to balance between what to be added to the system and how for the data entry operators or the medical records officers in this case to enter data into the system. Because immediate facility constraints. We have to use first introduce multiple into this even system, and the EMR was able to record only one diagnosis. Say patient comes with diabetes and hypertension, and he was treated for diabetes and hypertension. The system was able to because they had to decide between diagnosis. Implementation, we have to capture multiple diagnoses for these and can collect morphology codes for neoplasms, causes, and causes. First, we a manual and infant BH sector module in March, where the MROs are able to the pregnancy outcome delivery, whether it was a normal vaginal delivery or assisted vaginal delivery or a section, but the product and any other differentiated in the piloted in one of the main child hospitals in Sri Lanka called this hospital. Of linking our system with the Regional Department of Sri Lanka, the Registrar General information for me, I can email line and contribute courses which are identified with the system. Of Health is currently in the process of using a number, or we are going to call it personal health number. But MMR, it's not ready to capture this number. This number, though we say the 5 actions last year, those are just episodes. A patient with diabetes may have admitted to that hospital 10 times last year, but they'll be called the resting patient. But with the option of this personal health number, we are able to count according to patients rather according to admissions, and will be very soon will be a big case number diseases. Then the next step to capture the patient's restriction. This will enable us to give disease distribution according to many countries. There are systems being developed to, at the moment, there is a to develop a total hospital solution. MR is already equipped with to try system. Some of the screenshots of EMR is the main entry form with all the fields, and some fields are optional fields which can open to or will to the groups. Some of the fields will be opened after, say, the pregnancy records will be opened only that is related to a pregnancy. These are the search fields. This is one name, and these are the reports with the paper-based system. We will to get number of admissions or according to the groups that previously defined. Say for all were reported as one. MR report according to each CD code to the second decimal if needed. And just patient numbers. We can patient admission numbers, even days for individual disease, and days per disease. Further, we can data a code, and we can have chronological analysis of various diseases. Process of doing more as the system throughout the country. We are trying to get country reports through the system. Thank you for being in this video. Then we'll go for the question and answer. Thank you.
Thank you very much, Dr. Nadish and Dr. Buddhika. It was a well informative, elaborated presentation, and you surely inspired the audience with your web solution. We apologize for occasional disturbances occurred due to technical issues. I'm sure we're having a lot of questions to clarify from both of them. Please use the Q&A button on your right panel to type in your questions. We try our best to accommodate all your questions. We also provide the facility to ask questions through voice, provided you have a good internet connectivity and minimum background disturbance. Please in Q&A box if you are available for connecting online. We'll do the presentations done by Dr. Nish and Dr. Buddhika after the eHealth hour. We already have several questions asked from our audience, and we will forward them to Dr. Nish and Dr. Buddhika. The first question we have is from Dr. Jayatri Vijayaratna. She asks, if another country wants to adopt the system and wants to support, is it possible, and how is it possible at this moment? Dr. Nash, please.
Thank you for the question. Yes, certainly country-specific attributes of the system, but the way we have developed the system, it's adaptable to any country which reports this diagnosis. So if a country is happy to adapt our system, we are which caters to their requirements. Yes.
There's another question. Bimalka Vijayanayaka. Are there any private hospitals currently connected to the EIMR system?
Many, but we are in the process of starting with 2 hospitals in Colombo, which is reporting that this diagnosis. Able to name those 2 hospitals, but they already have a system to get their discharge data. It's ready with the API to extract data in the process of connecting to those hospitals, and probably it's ready. Will be a report private hospital as well.
Thank you for that. We have another question. What is the interface to analyze the gathered data? Is accessible to other stakeholders?
Very much for that question. Yes and no, because we have 6 user categories. One of the special user categories is called the edge user. Data user is a specific data user category which allows users just to retrieve data, but they are not able to enter any data into the system. But since data is, until it is published, it's not. Sorry. This user category, user category, we can customize data user category according to their requirements. For example, we recently introduced initial data user for the Health Bureau, where the Health Bureau is able to obtain maternal child health data. But there are public to obtain data, we registered with the to obtain such data.
Yes, sir. Should be okay. I think have not received any response from the person who has asked the question so far. We'll move on to the next question, and This is by Dr. Gayan Piasena. He asked, is the system able to capture vertical programs data? I repeat the question. Is the system able to capture vertical programs data?
The question are very clear what exactly mean by the question, but you are asking about whether we can collect SIP data. System is catered only for discharge diagnosis and things associated with the discharge diagnosis. Yes, we can we record as a program and share those data, but some kind of programs are not collected through this system. So if you can more specifically what exactly, give you a more detailed answer.
And if you are available to be through voice online, please let us know so that we can have you connected. In the meantime, I will move on to another question. This question is from Dr. Siad. He asks, as you mentioned, the data entry is done by trained medical staff. How the reliability of the data collected by the medical staff? Is there any certification for clinical coders? How can we improve the reliability of the data that is entered? Repeat the question. As you mentioned, the data entry is done by trained medical staff. How about the reliability? Certification for clinical coders. How can we improve the reliability of the data?
Well, for that question. At the moment in Sri Lanka, we don't have any universal qualifications for clinical coders, such as information management. But we have a training program for our medical records officers in the Institute of NIH or National Institute of Health Officers in Sri Lanka, where all medical records officers are trained on coding. But in our system, we have a validation process, which is intensive, which data entries to be reconfirmed, such as say a birth 55 years of but it's like or a diagnosis of cholera or A00, which is cholera. Cholera is very rare in Sri Lanka, but in a cholera, if the system would ask to reconfirm that data, and if the other aspects of the data entered, the system would ask, and if the is impossible, the system would. So this EIMMR has improved a lot in the accuracy from the paper-based system, but yes, we have some shortcomings, such as like we can really into the data entry place to check whether correct coded. But medical statistics unit at the moment have their own auditing process where they visit each see that they are up to date with their knowledge, and they randomly visit some of the hospitals to see whether they are doing their data coding accurately. Thank you.
We have a response from Dr. Gayan Piasena. He has mentioned, reading the previous question, I think regarding programs. It means those who do not need admission. For
Doctor, thank you very much for the clarification. Or hospitals, we don't have a process of following up patients who have already admitted and discharged, and we don't have a process of following up the patients. No, but the current country is now they are in the developing a system, and there are two OPD and clinic systems running throughout the country. So of health number, probably we'll be able to link the indoor patients with those outdoor patients. Hope I answered your question.
Yeah, Dr. Gan, if you need further clarification, you can mention in the Q&A box. No, I think he's satisfied with the answer and he has responded. And thank you, Dr. For the question you asked after the last questions you suggest to overcome the internet connectivity issues in rural areas. I think it's regarding the areas of Sri
Question was particular. I couldn't hear.
Yes, what are solutions you suggest to connectivity issues in rural areas?
We can internet distribution throughout Sri Lanka, because I think most about 60% of Sri Lanka, but at the phones go to all corners of the country, though the mobile connectivity is not there for the ADSL to most part of the country, and but we have a system developed for very small hospitals, very remote, where they'll into a admissions are less than 100 per year. There are very small institutions in corner of the country which have less than 100 to 200. They'll record data into a data form and send to a regional center. At the regional center, is fed into the EIMMR, and from there onwards it's treated as a normal data entered by a hospital. But probably with the soon, probably will be able to provide into the hospitals throughout the country, which would be useful for EIMR as well.
Okay, now we have a question for Dr. Buddhika from Kirti Dharmaratna. He asks, is there any mobile version or mobile application of eIMMR, or are there any suggestions, proposals for an application in future?
And actually, at the moment, there's no such version was developed, but it's rapid data entry process. So it is using desktop or laptop is essential most of the time. But if you can try for a mobile version, but for rapid data entry, for example, or in a hospital, they have to enter 4,000 visits a year. So using a mobile for that purpose is not suitable, we think. And Right.
Thank you for that answer, Dr. Buddhika. The next question is, if a hospital wants to add other modules to the system, which includes reporting to central levels, is that possible? I think what he tried to ask is if you want to add an additional functionality which is not non-existent, or any other modules that run parallel which can be installed to eMMR at this moment.
Question. Moment we have some optional modules such as obstetric module and neonatal examination module, but apart from that, able from already existing modules, but the use now it's a centrally controlled system where the medical studies in it, which modules to be used the institution. We are not connected to other systems, but PI is able to handle most of the connect to most of the hospitals in the country to data. But I'm not sure whether that answered the question.
I think actually we can wait for the response from the person who asked the question. In the we'll move on to the next question. It says, what is the program language used in designing of a eIMMR? Is there any particular reason for choosing that particular programming language?
We use PHP for program and MySQL for the database. There are a few reasons why we use Sri Lanka is a developing country which have limited financial resources and not supported so to a free open source platform. This the other consideration as well, such as ASP, but we PHP is one of the stable and one of the most used programming languages. Even Facebook is using PHP. It's better to use PHP. And for the database, we had two considerations. And then my no huge differences, but decided on using my. As for the previous question, someone was mentioning about a mobile application. We did that for data. In that case, we are trying to get an Android platform for mobile applications, but at the moment it has not been developed.
Thank you very much. The next question is, how are you prepared for privacy issues with lots of data collected in the system at the moment? Question, it goes as, how are you prepared for privacy issues with lots of data system now?
At the moment, we do not collect any personal data. No link between the patient and data other than the BHC number. So, though we consider the data security, but the introduction of a personal number, we need to consider at the moment, we are hosting this in a secured server, dedicated secured server in a location in Sri Lanka. So the data is secured, but we are trying to use encryption system for the national health number so that it's hard to retrieve, hard to record and person.
Thank you. I hope that answers the question. We have actually two more questions remaining, and I hope we would be able to finish by 1 p.m. as scheduled. Moving to the next question, it says, what is the scalability and sustainability plan of eIMMR? Do you have a dedicated development team or a company to proceed with development in future? An organization is planning to take a decision to move into eIMMR. I'll repeat the question. What is scalability and sustainability plan of eIMMR? Do you have a dedicated development team, a company, to proceed with development in future if an organization is planning to move into eIMMR?
Thank you for the question. Yes, about scalability and sustainability. We have already included eIMMR in Health Ministry annual budget. Funding for continuation of the project. At the moment, we don't have a dedicated team development. It is handled by the basically two of us. We have outsourced some of the parts, some of the modules, but we have to consider about a development team, which we have considered but not finalized yet. But regarding the sustain, probably since self-sustaining after development to a certain level, there are no real technical needs if the system is able. So that probably if there won't be any problem with the technical issues, but if we are to develop the system further, probably we need a dedicated
Moving on to the final question. It's, do you have a web API? If someone interested in linking MMR with another solution such as OpenMRS or DHIS2, what are the provisions currently available? I'll repeat the question. Do you have a web API? If someone is interested in linking eMMR with another solution such as OpenMRS or DHIS2, what are the provisions currently available?
Thanks for the question. Yes, at the moment we have an API can set to us, include OpenMRS. They have their own to talk to us, but at the moment haven't developed any system to our system. We have considered, but those interfaces are yet to be developed. But retrieve data from any which collects diagnosis and data connected to those.
Thank you very much. That concludes the Q&A session for today's eHealth Hour. We have run out of time. We'll be concluding the third Sri Lankan eHealth Hour for today. If you have any further questions to ask from Dr. Nadeesh Karyavasam and Dr. Puthika Dayaratne, please feel free to forward them to us. We will make sure to distribute the resource material and the answers to the questions to you via email. We will be grateful if you could also submit the feedback form we will be sending to you via email after this webinar. Please join with us for our next Sri Lankan eHealth Hour on 27th August 2015 at 12 noon. Dr. Arjuna Vijay, the Provincial Health Informatician of Northwestern Province of Sri Lanka, is sharing his experience on eHealth implementations in Northwestern Province of Sri Lanka with us. Expert in health informatics and willing to share your experience with the eHealth community of Sri Lanka, we can ask you a session at Sri Lankan eHealth Hour. Feel free to contact us. We are grateful for the participants today for sharing with us the valuable information. Also, Dr. Rushan Hewapathiran, CEO of eHealth, and my colleagues Dr. Megha Ganevatha, Dr. Jayatri Jaratna, and Dr. Siad, who were with me coordinating the eHealth Hour at eHealth. And I finally must thank all our attendees from around the globe. See you on 27th August. Bye-bye from Colombo, Sri Lanka.